Dr. Secord, you may want to comment on this, and Michelle, for many patients who are diagnosed, often if the diagnosis is made in the emergency room, that doctor may just not have the knowledge or the specialist expertise to guide you on next steps. What does this mean? What's the outcome? What's the treatment? When Michelle was first diagnosed in the emergency room, you were there as well, were you, Greg? So hearing that news for the first time in the lack of privacy of a crazy busy emergency room must have been very shocking.
Yeah, we're driving home at 3 in the morning, and it's a 30-minute drive home, and we're just driving in silence.
Well, we did start, and probably in the next day, we started talking about the side effects and how far back. It was over a year.
Right.
Yeah, yeah, because there's other things that were going on, some mood swings and just.
Oh yeah.
But you know, you assume it's all going through, perimenopause, and then you're going through menopause. So, and I didn't have any relatives to base this on, because my grandmother and my sister, my mother, they all had hysterectomies for one reason or another. So I didn't have anybody that I could talk to and say, how old were you when you were going through menopause, and how did this feel, and the whole incontinence thing. That's another thing. You talk about that with your girlfriends, and we just all laugh about it. Like, oh yeah, that happens to me when I work out, or if I'm laughing or something. But no one ever looks at it as an underlying problem. You just think it's part of old age.
And the time interval between leaving the emergency room and getting expert guidance on what to do next, what was the window before you saw Dr. Secord?
A week, less than a week.
So even in that week, there's certainly plenty of hours to jump on Dr. Google and start doing research. A week is not long, but when you've got 7 days, 24/7 to think about all these questions and issues, it's a long time. It's a lifetime of worry. What was going through your mind, Greg, at that time before you actually met with the specialist?
I really don't recall. I mean, I think it was just worry and doing the Google thing. I mean, trying to educate myself somewhat, because I knew nothing about it. I mean, I heard of ovarian cancer, but you don't, when you hear the words.
Denial too.
Yeah.
A lot of it's, you feel denial, like, no, this can't happen.
Dr. Secord, when a patient presents to you and you open the file and it's a new patient consult for ovarian cancer, is it a spectrum, or are there different subtypes of ovarian cancer that we know are more aggressive than others, or is it bad news for patients who present with late-stage disease regardless of the potential subtype of tumor that there may be in the ovary?
So it's a huge spectrum, and that's one of the things that we've learned about in ovarian cancer, where in the past it was, this is epithelial type, this is a germ cell type, this is a stromal type. Now we know that just in that epithelial group, there's all these different types: high-grade serous, low-grade serous, clear cell, mucinous, endometrioid, that can be either high-grade or low-grade. And that's not even all of them. And then within that distinct subtype, so for instance, high-grade serous cancer, like Michelle, you have these different molecular profiles, and probably at least 4 different molecular profiles for this high-grade serous type. So really we're drilling down to not just what we see under the microscope, but what's going on at the very biology of that specific tumor.
So when a patient like Michelle walks through your door, I'm sure you have some kind of pathological diagnosis, or at least imaging from scans like CAT scans or sonograms. How important is it for you at the start of treatment to determine the type of tumor? And does surgery always precede chemotherapy? Is surgery for everybody? Just give us a summary of the sort of treatment algorithm, if you will, for working a patient like Michelle up.
So in Michelle's case, she was young, and I alluded a little bit to this before, but someone who's young and relatively healthy, my preference is to go to the operating room, do a scope procedure first, so put in a laparoscope, small incisions. You can get a biopsy of the tumor to figure out what you're dealing with, send that to pathology in the operating room. They'll give you an answer within about 20 minutes in our team, and try to, if they can tell me what subtype, even better. Sometimes they can't give me that exactly, but if they can, it's awesome. And then we do a scoring method to say, can we remove all of this cancer or not? And if we can remove all the cancer, then we proceed with the bigger surgery. If we can't, and I'll do the surgery even if I can't remove all of it, but I can get down to 1 centimeter, what we call 1 centimeter of cancer left, and that's kind of these little spots. But if we can't do that, then we close those incisions and we do chemotherapy first. So we would do neoadjuvant chemotherapy, then come back later and do surgery.
And before we get into the specifics, for our audience who are watching this, who may have been diagnosed with ovarian cancer or have a loved one who's been diagnosed, you obviously have a huge amount of expertise in managing ovarian cancer. But for many patients who may go and see their local gynecologist, is that the point that we should really be advising women who've been diagnosed or have a suspected diagnosis? Your local gynecologist may not be the person to take this forward. Should we be recommending to women that they need to be evaluated from the get-go by an expert in managing ovarian cancer, even if it means they may need to travel to a different part of the country? Or can their local gynecologist, who may not necessarily have the expertise, can they actually assist in doing the initial hysterectomy and maybe laparoscopic biopsy?
So this is an area where I think it is so critical to see a gynecologic oncologist at the initial evaluation.
Before even surgery?
Yes, absolutely. There are some cases where I work with a medical oncologist, and they'll contact me about a patient, and we'll make a decision together on the phone. If he says this is somebody who's really too sick to undergo surgery, her nutrition status is very poor, this is the location of her disease, I might be able to glean from that this is somebody who needs chemotherapy first before surgery, so she can get started on her chemotherapy and see me in the clinic. But for the most part, I would say 90% plus of my patients see me first before that decision is made. Now, some of the viewers may say, well, of course she's going to say that. She's a G1 oncologist. It's very self-serving. But we have data. We have data that has been published that shows that women who get treated by a gynecologic oncologist, they do better, they live longer. And so I think it's really important to give yourself that best opportunity for either a chance at cure or the longest survival possible, to see a specialist who does this all the time.